Hello and welcome to this American College of Cardiology session. It's a faculty development session and we're here to talk about how to build an effective curriculum. My name is Jeff Kuvan. I'm a cardiologist at Tufts Medical Center in Boston and I'm joined by Carol Warrens, Professor of Medicine at Mayo Clinic. Carol, welcome.
Thank you.
We have you here because you have really done an amazing job at directing the American College of Cardiology Cardiovascular Conference at SNOMAS, an annual meeting at SNOMAS. And as director, we thought it would be helpful for you to help other potential directors of ACC activities develop a curriculum. So from a 25,000 foot level, how do you do this? How do you plan a curriculum? How do you take what you think is going to be a great end product and put it into action?
So I think the first thing is to know your audience. This is a program that has a very long history. And I think the first thing is to understand what the audience needs are. For a general cardiologist, the desire to get knowledge from this program is very different from, for example, a cardiology board review course, where they want to get information and facts fast and furious, no controversies. Give me the gist of the information. I want to learn it now so I can pass the test. Very different, I think, with a general cardiology audience. So the first thing is to know who your audience is, and then to build on needs assessments and knowledge gaps. It was quite a challenge because this is a program that has a very long history, but fortunately, we've built on a lot of data. So the first thing was to figure out what were the educational objectives for this particular program and where are the needs assessments and how deep do you dig. So fortunately, what we had was a lot of data from the past, but we also wanted to build then from current data. And we mined ACC data to help us do that. So what's the information that we've got from self-assessment programs? What were the information we got from testing from last year's audience? And fortunately, I introduced MOC testing in SNOMAS for the first time so that we could really get to understand where the knowledge gaps were within that particular audience. So not just the audience of cardiologists in general throughout North America and broader, but also for that particular audience. And we used pre-tests, for example, so we sent out a small poll of a dozen or so questions. And then when you build on those knowledge gaps and the knowledge gaps you have from MOC questions from the time before, you start to build on that a very specific curriculum to fill those knowledge gaps. So it's a lot of work. You really have to figure out what your learning objectives are. And fortunately, one of the things I think that's helped, as you know, is that ACC has now developed curricula for all of the knowledge pathways: heart failure, arrhythmias, congenital heart disease, everything. And figuring out what the competencies are for all of those learning pathways. So if we look at those, and I've read most of them now as we're going through the SNOMAS curriculum for next year, what do these subspecialists who've dug into these needs assessment for that particular pathway, what do they think is important? Where do they think the knowledge gaps are? And then what I'm doing is I'm feeding that information to the selected faculty and say, you know, these are where the gaps are. Can you focus on this? This is what the college has developed. And then lastly, looking at everything that's been published in the last year or two in terms of scientific statements, appropriate use criteria, guidelines, what's current and topical that we need to get out there for the audience to know, because we're being bombarded by so much data currently, we can't keep up with all of it. So what is there new? What does this quite sophisticated audience need to know for their practice? And so it's sort of gone from the old teacher-centric, I know what you need to know, I'm going to teach you, to data that we have in broad cardiology from SAPS and testing, to MOC data we've accumulated from last time, to polling this specific audience and trying to put it all together and give that to the faculty so they can start to create what's important, what are the learning objectives, and what do we want to accomplish from this particular program. It's actually a huge amount of work, obviously, but a lot of fun.
Sounds like it. So know your audience, do an in-depth needs assessment, and then talk to your faculty and make sure they understand who they're teaching with and who they're teaching to. We've heard this term backwards planning, thinking about the end result of what you want to happen. Do you ever incorporate that into your curricular design?
Yes, and I think effectively that's what this process is. So by, for example, focusing on this specific audience, if we test them beforehand and we know what our learning objectives are, what outcomes we want to accomplish, if by pre-testing we discover that there are gaps for this specific audience, then we can modify the program and modify the faculty focus of where their topics need to be. So it's a term I confess I'm not particularly fond of because it sounds a bit schizophrenic. We're looking backwards to go forwards, but I understand the principles, and very much I think you have to think about what do we want to accomplish before you start out developing the whole program.
Right. Now you inherited this program. It's a long-standing program, 40 plus years. How does it differ inheriting a large program like this versus starting a curriculum by yourself?
I think it's very different. As you say, there's a huge history, both from the audience and the faculty. Some of the people, in fact, many of the people who come to this particular conference have been coming to the conference for 20 or 30 years. And they have expectations about how it should be. And many of the faculty have been coming for years also, and they have expectations that they should be invited again, and maybe how the program should be. And change is difficult for all of us. And how do you make those changes if you have ideas as you take over a program? It's a program I've been coming to myself for many years, initially as an audience member, then as a faculty, and then a co-chair for a year, and then sort of diving into it as chair for the last couple of years. So there are these expectations, and perhaps then one would say you have to introduce change incrementally rather than in one fell swoop, and try and explain to the audience why you're doing it, and very much encourage their feedback. We're making changes. We're changing the footprint, for example. Instead of being a whole week-long course, we changed it to fewer days because we felt we wanted more people to come. More younger people who might be able to afford to be away from practice for a shorter period of time, and if they wanted to bring family and stay longer, they could. But explain to them why you're suggesting changes, and at every step we polled the audience. So for example, when I introduced MOC session, many of the audience, I think it was about 50%, said they weren't recertifying for MOC. So why would you introduce MOC? Oh gosh, maybe this is a bad thing. But in fact, they discovered that case-based learning with audience response, they loved it. It didn't matter to them whether they were participating in MOC or not. Hopefully they will do as time goes on. But it was a format that they absolutely loved. And so, you get their feedback and you build on all of that. So incremental change, new ideas, tell them why we're doing what we're doing, and try and have them understand that we're trying to make it better for everybody.
Interesting. So again, incorporating know your audience yet again. So you mentioned some educational changes. We know now that we probably need to teach less but educate more. So how did you incorporate new educational techniques into Snowmass? Give us some examples, if you will.
So I would say MOC would be the number one, very popular. And it gives us the ability to, again, know where the knowledge gaps are. For example, if you learn from MOC testing that one example in my area was valve disease and pregnancy, congenital heart disease, knowledge gaps were huge. We learned from that, we got the data, we're able to teach them, but it also then helps you develop the curriculum for next year. This is something we need to focus on. Novel antiarrhythmic therapy that's new, novel anticoagulants, different strategies. If you learn that that's a gap, then you can build on that for the next year. And we've introduced some new things as well. We actually introduced breakout sessions. One of them was heart songs, so for an audience to test their capabilities of auscultation. We talked about shared decision making. So we had a movie with an actor making decisions about TAVR and how do we really incorporate patient decision making, again very much with audience interaction, discussion, and various breakout sessions with a lot of audience interaction with the faculty. We had a speaker talk about how can you use NCDR for quality improvement initiatives in your own practice. So some new ideas that we're trying. One of the others that we tried for the first time last year was this concept of the flipped classroom. And I didn't know whether anyone would go for it, but the idea is, as you know, is that the audience participates in a learning activity before they ever get to the course. And then you have a lecture when you're there on much of the same topic. But some of the audience have already gone through their homework online. We had it on CardioSource. And then we tested them as we were going through to see, and we knew which of the audience had done the online program and which of them hadn't. And then we can test them to see had they actually learned anything from the online program versus those who had never done it. Concept that's used in schooling quite a bit nowadays. And I used something that was very concrete because I didn't want anything that was open to a lot of interpretation. So I used interpretation of ECGs and used one of our EP speakers and just said, okay, let's do 5 or 6 common mistakes that people make in practice. Show the ECGs. This is a 10-minute online thing. Let's see how people learn. And then he did a talk on common mistakes in ECG interpretation, not using exactly the same ECGs, but ones that are very similar with the same principles. And then we tested people to see had it worked. And so this is something also I think we're going to build on. So lots of new ideas. Whether they'll come to fruition, we'll see. But
that's great. How do you measure success? I mean, do you measure it by the outcome of an examination? Do you measure it by, is there going to be change in clinical practice? Do you measure it in patient outcomes? How can you measure success of a conference like this?
It's challenging, as you know, and there are various layers that we all measure, from the most simple of how many are attending to did they like the course. But much more importantly, as we try and build on that, did we actually change a physician's knowledge base? So pre-testing and post-testing. And a big component part of that, of course, is case-based learning. Again, are we changing a physician competence? Are we changing physician performance? Our plan would be now to try and follow up with a post-test with case-based learning to see, are we actually starting to dig into competence? And heart songs was a great example of that. I think auscultation, we'd all agree, is something that's slipping in our training. And so we were able to test physicians beforehand and afterwards. So there are many levels. I think if you look at outcomes for the learner, that's one piece of it. The other aspect I think that's more challenging is how do you measure the success or failure of the whole program? And that's more challenging. It goes beyond did they like it and did they learn? And this is something that our outcomes and assessment group is trying to look at to come up with some sort of scorecard of what makes a program a success. For example, it's not just is it financially successful, which you hope it is, at least you can break even, and not just do people come, but are we engaging the audience? Are we changing physician behavior? Are we demonstrating that learning has occurred? Can we demonstrate that they've put that knowledge into practice as competence changed? Is the program innovative? Are we introducing new things? How much of the new guidelines and scientific statements that have been published in the last year or 2 years have we incorporated into that program, or is it all old news? And I think we need to look across the board at all of that to determine whether or not it's a success. And as the college moves forward in this, looking very critically, I think, at all our programs, we need to look at the whole balance of what the curriculum is. Are we meeting fellows' needs? Are we meeting the senior cardiologist need? What about the whole healthcare team? And we need to look at all of those metrics somehow, and we're beginning to build on that, but it's a challenge for the college, and I'm sure we'll do it moving forwards.
You've been very successful as an educator and teacher. If you could encourage younger faculty to participate in curriculum design, what are 3 words that you could impart on them? What are the 3 main themes, if you will, that you think are important for young educators?
I'd say first get a mentor who will give you constructive criticism, both about your content of your talk, how to present, how to think about developing learning objectives, and to really critique you when you're presenting. And I think that's a good beginning and extraordinarily helpful. It was for me anyway. Second, I'd say begin to get involved in the college activities, whether it's question writing, some of the education committees that are involved, and so that you can start to learn some of the education principles that are involved. How do you develop needs assessments? How do you do a gap analysis? How do you validate what questions are appropriate? How do you begin to develop a curriculum? So get involved with the college. Start small, then get on some of the committees. If you can, participate in the emerging faculty program. So many people have told me how hugely important that was for them as a speaker, but also getting involved in all the education. I guess practice in your own institution. Begin small. Think about when you're giving presentations, what are my learning objectives? How do I do it? And if I'm putting on a program in my institution, think about how you apply those principles in your own place, so that hopefully you can build on that experience and then do it nationally and maybe internationally if you're a success.
Thank you very much, Carol. That was really a great session on how to build a curriculum. And thank you very much for joining us.